afternoon, everyone. Thanks for having me today. I'm going to present on my QI project, which is about to improve the rate of cervical cancer screening in Hougang Polyclinic. And the mission statement is to increase the rate of cervical cancer screening uptake in eligible females aged 30 to 69 from 28% to 50% in Hougang Polyclinic over a 6-month period from July 2024 to December 2024. Cervical cancer screening, as we know, is an important cancer, especially amongst our female patients. And for that reason, precisely because the precursors to cervical cancer screening, such as CIN, is often silent and asymptomatic, all the more it is important to screen for this disease. I've listed the definitions up on the screen as follows, with the indicator being the percentage of eligible females aged 30 to 69 who have undergone up-to-date cervical cancer screening. The criterion is that women who have ever undergone sexual intercourse between ages 30 to 69 should go for cervical cancer screening or HPV screening. And finally, the standard is that 50% of women who have presented to Hougang Polyclinic in the appropriate age group of 30 to 69 should have undergone some form of up-to-date cervical cancer screening. My team members are as follows, and the flowchart is as follows, where we aim to intervene specifically in areas of the micro workflow where patients present to us. Before starting the project, we did a survey amongst 10 female patients between the age range that we were investigating and asked questions based on the National Population Health Survey to seek their understanding of cervical cancer screening and their attitudes towards it. Survey response showed that patients, number one, were largely unaware of the appropriate cancer screening intervals, with some misunderstandings towards the procedure as well as cervical cancer screening as a whole. This helped us form the basis of our root cause analysis. We identified quite a few root causes and eventually came down to the Pareto chart, where we listed down 5 main causes, but after voting, we came down to 2 main root causes, which was suboptimal staff knowledge as well as suboptimal patient education. This guided and framed our intervention and PDSA cycles. Altogether, we went through a PDSA cycles 1A, 1B, 2A and 2B, and the first PDSA cycle 1A, cycle 1A intervention sought to raise awareness of doctors in the CCS workflow, resources, and national screening guidelines. This came in the form of a CME, clinic-based, and after the CME, we surveyed 9 doctors regarding their experience, and the feedback on the whole was that while the CME was useful, it was difficult to retain all the information all at one shot, and everyone hoped for a resource that consolidates knowledge and commonly asked questions that patients may have to serve as an aide-memoire during consultation. And that led to acting, which is creating 1B, the creation of ready-to-access modality that doctors have access to during consult, and this was an EPIC smart phrase, as most of us be using right now. The rollout of this smart phrase came to all the doctors in the polyclinic after an initial pilot with some of the other doctors. And the feedback after this was that doctors, the feedback gathered is that after 2 weeks of using, 5 out of 7 found that they had used the smart phrase, and amongst those who have used, most of them have found it useful during consult. And so no further modifications were made in this PDSA cycle. The subsequent one focused on patients' education, whether the patients knew about the process of CCS and the benefits of CCS in reducing the incidence as well as mortality of cervical cancer. This came in the form of patient education leaflets gotten directly from HQ, and after giving out, we found that most of the doctors found it was cumbersome and they had not given out the information sheet during consult. And most of them stated because the physical copy was difficult to issue during consult, and that led us to make resources that were easily available, both outside of consultation setting, meaning the doctors did not need to physically offer it, as well as something that the patients can scan and not physically need something. Therefore, we came up with a QR code which transcribed each of the digitized form of the patient information leaflets and put it all around the polyclinic. Having surveyed 6 patients who had read the digital PEM, they found that most of them reported an increase in understanding of cervical cancer screening, and amongst those who did not report, they just stated that there wasn't enough time to go through the entire brochure. But everyone stated that having the brochure and the QR codes made them more curious about cervical cancer screening as a whole. Given the results, we tracked the percentage of eligible females who had undergone screening, and there was a steady increase from 28.6% all the way to 28.9%, but it still fell short of our goal of 50%. Limitations of the study would include the delayed effect of interventions, the data being confounded by ongoing HSG efforts, and finally a lack of washout period, where there should ideally be a washout between individual interventions to avoid stacking effect of the individual interventions. The lessons learned as well as strategies to sustain are as follows. And overall, advocating for preventive health is a crucial part of our role as healthcare professionals. And educating patients about their health is key tenet to bolster preventive health. Proposed strategies to make sure this project is sustainable in the future would be regularly conduct CMEs, especially to apprise new joiners to the institution of existing guidelines, continued use of PEM, both digital as well as physical if needed, as an education tool for patients. And finally, working with corporate stakeholders to augment existing efforts. For example, putting institution-wide videos outside consultation rooms where patients are waiting to educate these patients on cervical cancer screening. So this brings me to the end of my presentation, and thank you so much for your attention.